Can you not see me at the moment?
Nope.
Okay, so it's live now.
Okay. Yeah, just interrupt me at any point during, if things are looking weird.
Okay.
Yeah.
I don't know how we can see when people are joining. People, let's have a look. Okay, everyone's joining now.
Good.
Okay, so we have 13 people. 18. Someone has said greetings from Belgium. Hello. Okay. Okay. So hi everyone. We're going to make a start now. Thank you for joining today. My name is Gabby and I'm the education coordinator for SUPTA. This week we're going to be focusing on lower GI. And we're really excited to have you all with us. Today I'm joined by Kiara, who will guide you through lower GI anatomy and small bowel. Kiara is at Imperial and is a 5th year medical student. To make this session as engaging as possible, we'll be releasing some polls throughout. These are completely anonymous, so we encourage you to participate actively. If you have any questions during the session, please pop them in the chat and we'll do our best to address them. At the end of the session, we'll share a feedback form. If you complete this, you will receive a certificate of attendance and exclusive discount codes for Teach Me Surgery and pass their MRCS. Additionally, this session is being recorded. The recording and slides will be shared on our medal page a couple of hours after the session, so please make sure you keep an eye out for that. We're excited to share that an exclusive question bank and other resources will be available on our learning portal, so be sure to check out our website to access them. If you create a free membership account with us, you'll automatically receive a discount code for 10% off Geeky Medics anatomy flashcards, surgery flashcards, and knowledge bundle. We also have an exciting opportunity for all our attendees. 2 lucky people will win free access to the Geeky Medics surgical flashcards and the Geeky Medics OSCE stations. To enter, simply complete the Google form at the end of the session and enter the unique code we'll provide. The more sessions you attend, the higher your chances of winning. So be sure to stay until the end of today's session and attend as many of our other sessions as well. Finally, before we begin, we'd like to thank our partners, the Royal College of Surgeons of England, Geeky Medics, the MDU, More Than Skin Deep, Medal, Teach Me Surgery, and pass their MRCS. And without further ado, I'll hand it over to Kiara now.
Perfect. Thank you so much, Gabby, for the introduction. So my name is Chiara, and I am a 5th year at Imperial. I did my BSc in gastroenterology, and I like a lot of things to do with the bowel, weirdly enough. So I am very happy to be giving you this lecture tonight on anatomy and the small bowel, and thank you very much to SUPTA for having me. So these are the SUPTA's partners, as Gabby has mentioned. There are a couple of learning objectives tonight. This is the first section of the talk, so we're just going to describe the general anatomy of the abdomen. So we'll cover what the abdominal cavity is, a couple of surgical landmarks like Callow's triangle, Hesselbach's triangle, the inguinal canal, and we'll also talk a little bit about the abdominal walls and what the peritoneum and mesenteries are, which I found really confusing until a couple of years ago. We're also going to briefly describe the organs in the lower GI tract, so starting from the small intestine down to the anal canal, and we'll talk very briefly about those and their functions and what they look like, essentially. And we'll also describe the arterial supply and venous drainage of the lower GI tract. And we'll also cover some conditions. Now, these aren't strictly small bowel conditions, but they're still important GI conditions overall to know about. So inguinal hernias and femoral hernias for sure. A hiatus hernia I would classify more as an upper GI condition, but we've grouped it together with the hernias just because the principles of investigating and managing them is quite similar. And then we'll just talk about gastroenteritis, which is super common and something doctors in training will be facing all of the time. So we'll start with a brief introduction to the abdominal cavity. In the easiest terms possible, the definition of the abdominal cavity is a space between the diaphragm, so here just under the thorax, and the pelvic brim. And that is what we mean by the abdominal cavity. The boundaries, it will be bound on all of its sides, so superiorly, inferiorly, both anterior, so the front, where your belly is, laterally, so on the sides, and posterior around the back. Its superior border is the diaphragm. Its inferior border is the pelvic inlet, and it is surrounded by the abdominal wall, both anteriorly and laterally. And then posteriorly, you will find the vertebral column and the muscles. And we'll go through this in more detail. Clinically speaking, it's usually split into 9 different regions. A lot of you that are training in the UK will have had this for your OSCE practices of examining the abdomen. You always see something similar being taught to you. And it's very important because pain in each of these regions guides you to a different diagnosis in the abdomen. So that is an important slide to understand. And also when you're describing to clinicians in the future. To make things a lot simpler, most of the time I just use the 4 quadrants, so I don't have to remember 9 different names. Right upper, left upper, right lower, left lower. That is always a good starting point for describing anything in the abdomen. So we'll start with the abdominal wall now. And so we're going to focus on the anterolateral abdominal wall, so the front of your belly and the sides. So the anterolateral abdominal wall, it consists different layers, and these are very important layers to understand because not only do they protect you and they allow you to move and they support all of the organs in your abdomen, it's very important to understand the order that they come in. Because in almost all types of abdominal surgery, you're going to be cutting through those layers in order to get to the organs underneath. So we'll start with the lateral abdominal wall, which is the abdomen on your 2 sides, essentially, and what are the layers of the abdominal wall on the 2 sides. So you'll always start off with the skin. That is what you see, and your skin is the outermost part of your abdomen. And then if you cut the skin open, you're going to see fat. And that is usually your subcutaneous fat. But specifically in the abdomen, it is also known as the campus fascia. And below the campus fascia, you'll see the scarpus fascia and the superficial investing fascia. In real life, when I've seen them, you can barely make it out. but it is just a thin layer that you would find, a membranous layer that you find under the fatty layer once you pass the skin. Once you separate that, you will hit the muscles, which there are 3 different types of muscles in the lateral abdominal wall. So on your sides. And if you think about it, if you're doing a side plank and you're training your obliques, those are the muscles that you're trying to train. So your external obliques comes first, and they sort of go in a downward direction. And then your internal obliques will go perpendicular to that. So they're kind of crisscrossing to make sure that it's nice and tight, and to be able to withstand your intra-abdominal pressure that is generated by your organs. So those are the first 2. And then past those 2, you find the transversus abdominis, which is going horizontally. So those are your 3 muscles that you have to get through on your lateral wall. And together they're known as the obliques very colloquially. Then you're going to get to the peritoneum, which I think is, when you're cutting it open in real life, is realistically what you're going to be able to identify next. And this is just another layer, which we are going to go through in a bit more detail in a second, that is protecting your internal organs. So it's the last thing that you have before you get to all of your abdominal organs. And we will find out that it is quite a fatty layer, and that its job is to separate the muscles from the organs and to make sure that the organs are nice and protected. So remembering the layers of the abdominal wall, super important. The best place to find out and see it, actually, weirdly enough, is if you ever go and do a C-section when you're on gynecology. I know people on here probably want to be general surgeons maybe, but doing a C-section is a great way to see the layers of the abdominal wall over and over again. So I would recommend that. Now, so we just talked about the lateral abdominal walls, so around the 2 sides here. We're going to talk about the differences with the anterior bit of the abdominal wall. So around the front, what is different? Essentially, it's exactly the same, except that you have the rectus abdominis muscle on the front as well. So on the sides, you have your obliques. So your external oblique, your internal oblique, and your transversus abdominis. But in the front, you have your abs, essentially, the rectus abdominis. And 2 important things to appreciate in the anterior abdominal wall is your linea alba, which is this layer down, this tendon down the front, and the arcuate line, which is a bit of an arbitrary line, but it's important to understand. So if we imagine that you are looking at the patient sort of from their feet upwards, so what you would usually see in like an MRI, this is your rectus abdominis muscle. So these 2 bits here correspond to one muscle here and the other muscle here. And you can see the linea alba here in the middle, which is this bit running down the middle. And above the arcuate line, so above this arbitrary line here, you don't actually see anything in real life. There is like a covering, a rectus sheath that we call, that covers the rectus abdominis muscle, both anteriorly and posteriorly. So both in the front and the back of it. And that makes sure that it is a really strong layer there, that supports the abdomen and all of the organs and makes sure that everything is nice and compact. And then for some reason below the arcuate line, so below this area here, it loses the sheath loses its posterior covering. So your rectus abdominis is not actually covered at the back anymore. And that is quite clinically important because this makes the abdomen on this side a lot weaker. And this is why you can often get a lot of hernias and outpouchings in this region. So that is the rectus sheath and the arcuate line. Moving on now to the posterior abdominal wall. The posterior abdominal wall is made up of different structures, and it is just a very strong musculoskeletal region that supports again, supports all of the abdominal organs, and it also acts as a conduit for your nerves down your spinal cord, and vasculature, so blood vessels. And it is very important to make sure that you are stable as a person and you maintain your posture. And it also protects lots of organs like the kidney, the aorta, and the inferior vena cava, which are retroperitoneal. And I will explain what that means also in a second. And commonly people will say the posterior abdominal wall is made up of the diaphragm, the back of the diaphragm, and these major muscles here. So the psoas muscles split into major and minor. You see the major psoas muscle here and the minor psoas muscle here, and then also the iliacus. It's from my anatomy exams 3 years ago, we had to learn the insertions, which are very important, but I will not bore you all with that here today. But that is important to know if you are doing your anatomy exams or want to know more about it. Understanding where the muscles originate from and where they insert is important. And then your other posterior abdominal wall muscle is your quadratus lumborum, which stretches also on both sides. So on this diagram, it would look like this. Basically, you have to imagine them kind of in this direction. So yeah, I said we would talk a little bit about the peritoneum, and that's what we're going to do. So the peritoneum, if I remind everyone, is this last layer here that you find deep to the muscles and just before the abdominal organs. And it's split into 2 different layers, essentially. The parietal peritoneum, which lines the abdomen and pelvic walls, and the visceral peritoneum, which covers the abdominal organs. So one is stuck onto the walls and the other one is stuck onto the organs that exist inside of those walls. And together, if you can imagine that there's one layer here and the other layer here, and they kind of rub against each other, and there is a space in between the 2 layers that is known as the peritoneal cavity. And it usually contains serous fluid to make sure that everything is nice and lubricated, and that the organs can slide around without being stuck. So quite similar to your lungs with your pleural cavity, where it just makes sure that everything can expand and contract without causing too much friction. So in the abdomen, the peritoneum is also formed into the greater omentum and the lesser omentum. So the greater omentum is this bit here. I don't know why it says gastro. That is the stomach. And the greater omentum is just a very fatty layer, essentially, and it is peritoneum. So it's that layer there that how it protects the bowels, but it attaches from the underbelly of the stomach, essentially, and drapes all the way down to cover your small intestines and your large intestines. And your lesser omentum is above the stomach, so in this bit of the stomach, and it is covering all of the ligaments and the vessels that are going from the stomach to the liver. So if you imagine the liver kind of sitting here in this bit, the lesser omentum is covering the portal triad, which we will cover later, which is very important and needs to be protected as it is a huge blood vessel, and you wouldn't want that to be damaged because you would bleed out. And yeah, so it's also important to know that the peritoneum is split into the greater omentum and the lesser omentum. The greater is here and the lesser is here. And then there's also a separation between intraperitoneal and retroperitoneal organs. So intraperitoneal organs are those that are completely covered by the visceral peritoneum. And this is a bit of a list here. Essentially, most things in the abdomen are intraperitoneal, which means it is completely covered by the visceral peritoneum, which is the peritoneum that is sticking to your organs. So it is completely covered front and back, and completely protected. Things like your stomach, most of your small intestine, your liver, your spleen. And retroperitoneal structures are those that are only partially covered by peritoneum. So usually only the front bit is covered by the peritoneum. And so these are things like the kidneys, the ureters, the rectum, and a mnemonic for understanding which ones are retroperitoneal is sad pucker, which I found quite entertaining when they first told us. And so suprarenal glands, the aorta, and the inferior vena cava. The duodenum, only your second and third part of your duodenum, however, because the first part is intraperitoneal. Your pancreas, except its tail, the ureters, the colon, the ascending and descending parts of the colon, because the transverse and the sigmoid colon are intraperitoneal, and they will come in and out of the peritoneum. Your kidneys, esophagus, because it is American, and your rectum. So unfortunately, I haven't found a better way of memorizing what retroperitoneal structures are, except using this mnemonic. If anybody has a better idea, please feel free to share. But it's just, I think, one of those things that once you rote learn, you'll know. And again, it's very important to know which ones are intraperitoneal and retroperitoneal. Obviously, surgically, when you go into the abdomen, you want to know which ones are covered by more tissue that you might need to divide than those that are not. And it also influences how you access all of these organs. So, for example, for kidney surgeries on your ureters and kidneys, you will often go from the side instead of going from the front, because it would make no sense to go through everything in the front, go through the peritoneum only to get to the back. And if you approach it from the back, then you save yourself a lot of hassle. So how anatomy influences surgery is hugely important. Okay, so our first question here, and this is going to take a little bit of synchronization between myself and Gabby. Which one of the following describes campus fascia? Is it a membranous layer that is deep to the scarpus fascia, so below the scarpus fascia? Is it a fatty layer that is more prominent in the lower abdomen? Is it a fibrous sheath that is enclosing the rectus abdominis muscle, or is it a smooth muscle that contributes to intra-abdominal pressure? And Gabby, please let me know if we have any answers coming in.
So we have 3 responses so far, so I might wait a few more seconds. Seven responses now. 8. Okay, so I'll announce the percentages. So 55% have voted a membranous layer deep to scarpus. 18% have voted a fatty layer more prominent in the lower abdomen. 18 have voted a fibrous sheath enclosing the rectus abdominis, and 9% voted a smooth muscle layer.
Perfect, thank you. So those of you who voted B was correct. Is a fatty layer more prominent in the lower abdomen? So a lot of people went for the first option, which is a membranous layer deep to the scarpus fascia. And the catch to that is it's a fatty layer. So first of all, it's a fatty layer and not a membranous layer. And it is also, it's not deep to the scarpus fascia, it's actually above the scarpus fascia. So it's the first fascia that you would come to after the skin. So you can see here, campus fascia comes before the scarpus fascia. B is correct because it is a fatty layer. And I was quite mean because I did not actually say that it was more prominent in the lower abdomen. But if you think about it, where are most people's subcutaneous fat, and where are people storing more fat in their abdomen? Essentially, it's in the lower side. So that is correct. C is incorrect. A fibrous sheath enclosing the rectus abdominis is the rectus sheath. It has a very specific name. And a smooth muscle layer contributing to intra-abdominal pressure, that would be the transversalis abdominis, sorry, here. So B is the correct answer. Okay, we'll move on to talk about some of our other anatomical landmarks, the first one being the inguinal canal. So the inguinal canal is a passage in the lower abdomen that serves as a pathway between the abdomen and the external genitalia. It's clinically important because you get lots of inguinal hernias, and it is a very common site for it. To remember the boundaries of the inguinal canal, I use the mnemonic MALT. So M for muscles, and that is describing what forms the roof of the inguinal canal. So the internal oblique and the transversus abdominis muscles. The pink bit here is, as you can see. So if I orientate you, this is the right side of someone's pelvis. This is the ASIS here, and this is your pelvic symphysis, I believe. And the roof of your inguinal canal is traveling in this direction, and it is your muscle, so your M. Then the anterior border of your inguinal canal is the aponeurosis of the external oblique. Aponeurosis meaning where basically the external oblique ends, and that is the navy bit here. Then L for ligament is the floor of your inguinal canal, and that is your inguinal ligament. Let me go back. And that is the green bit here. It's really hard to see it, but it's essentially this section here. And that is the floor of your inguinal canal. And then T for transversalis fascia, which is the posterior bit of your inguinal canal, which you can see here. So yeah, essentially it is this section here, which has structures which we will go through passing through it, and it is just the conduit between your abdomen and your external genitalia. The contents of the inguinal canal, you can remember with I love creamy nice. Please forgive me, these things are really stupid, but the stupider they are, the easier it is to remember. The most important one being the ilioinguinal nerve. So for I, which is passing through this region. You also have lymphatics passing through, your cremasteric muscle in males, and which is very important for the cremasteric reflex. And then the ice part of I love creamy ice is split into two different structures depending on whether you are male or female. So in males, that is the spermatic cord. In this diagram, this is a male, and you can see the spermatic cord just coming out here, and that will lead into your scrotum. And in females, that is the round ligament of the uterus. So yeah, remember that. I love creamy ice. And remember that the ilioinguinal nerve passes through that. There might be a question on it later. Then we move on to our second surgical landmark, which is the Callow's triangle, also sometimes known as the cystohepatic triangle. And this is quite an important one for hepatobiliary surgeons and general surgeons, just because they do lots of cholecystectomies. Cholecystectomy is when you remove the gallbladder. Indications for that can be gallstones, and for example, and identifying this triangle is quite important to make sure that you don't cut the wrong structure, essentially. And the triangle is this gray structure here. So if you can appreciate, there's a triangle here. And the superior border is the inferior border of the liver. So this inferior border is the superior border of this triangle, as you can see, this bit. The medial border is the common hepatic duct, which is here. And then the lateral border is the cystic duct, which is the duct leading to the gallbladder here. And the inner cholecystectomy, this is really helpful to orientate yourself and you know that you have to ligate the cystic duct and the cystic artery, so you don't go around cutting other ducts around here. You make sure you only cut through these two structures to safely remove your gallbladder. Okay, next question. So which of the following structures passes through the inguinal canal in both males and females? So is it the spermatic cord that passes through both males and females, the round ligament of the uterus, the ilioinguinal nerve, or is it the inferior epigastric artery?
Okay, I can see responses coming in. We've got 7 responses so far. Okay, so no one has voted for spermatic cord or the round ligament of uterus. 87% voted for the ilioinguinal nerve and 12% voted for the inferior epigastric artery.
Good. Okay, perfect. So most people got it right. The correct answer is the ilioinguinal nerve. And if we go back to this slide on the contents of the inguinal canal, you can see that the ilioinguinal nerve is one of the structures going through, and the inferior epigastric nerve artery, actually does not go through the inguinal canal. So the correct answer was C, the ilioinguinal nerve. So well done to most of you. We're now going to move on to chat a little bit about the organs in the abdomen. We'll start off with the small bowel. And the small bowel, anatomy-wise, is really easy to remember. It starts at where the stomach ends, here, and it starts with the duodenum, and then that kind of wraps around in a C shape, and then after that it's just a long tube until it gets to the colon, essentially. It's split into the duodenum, the jejunum, and the ileum. In real life, there is no structured, this is the duodenum, this is the jejunum. It's more of a rolling scale, if you will, of small bowel. And what determines duodenum from jejunum is just differences in their morphology. That makes it slightly different. So they morph into each other instead of there actually being set bits of duodenum or jejunum or ileum. The first thing that differs between the first bit and the end of the small bowel is wall thickness. So wall thickness will decrease from the duodenum to the ileum. The duodenum has the thickest walls because it needs lots of glands to secrete enzymes to help digesting food. So all of the food that comes from the stomach gets emptied into the duodenum, and the duodenum, especially the first third of it, is still responsible for digesting your food. So it will secrete lots of enzymes. The gallbladder will secrete bile into there, and the digestion process is still happening at that point. And the walls are really thick to make sure that they can house lots of glands to secrete those enzymes. And then as you go through to the jejunum and then the ileum, by the time you're in the ileum, you are absorbing things. And you want to make sure that your walls are as thin as possible so that your molecules do not need to travel miles to get to the blood vessels, in very colloquial terms. So it's very easy to remember in a sense. Just remember that in the duodenum, it's thick because you still need to secrete enzymes, and it gets thinner because you want to start absorbing more and more as you go towards the ileum. You get these things called plicae circularis in the small bowel, and they are just folds in the small bowel that help absorb, increase the surface area for absorption. And in fact, most of the absorption in the small bowel actually happens in the jejunum. Your ileum will start absorbing your last things and start absorbing a little bit about of water, but most of it happens in the jejunum. And so, as you can imagine, you want to make sure that the surface area of your small bowel is as large as possible to make sure you can absorb as many things as possible. So as the walls in your small bowel get thinner, these plicae circularis will increase, certainly in the jejunum. There are some in the duodenum. Then your jejunum is very, very rough like this, and full of these plicae to make sure that your surface area is large. And then by the time you get to the ileum, this is slowly starting to fade, with almost none by the terminal ileum. There is also a difference in terms of blood vessels in the small bowel. So the jejunum will have less arcades being these circular-like structures, but very long vasa recta. And the ileum has many arcades, but much shorter vasa recta. And that makes it much better for absorbing smaller molecules that haven't been absorbed in the jejunum yet, and also starting to absorb a lot of water. Moving on to the appendix now. So we were just talking about the small intestine, or the small bowel, as we say in the UK. And the appendix is this narrow worm-like extension of the cecum. So the cecum is the first part of the large bowel. And there is increasing research saying that it does play a function in terms of immunology-wise, but the general saying is to say that it is useless, except when it decides to get inflamed and infected, and we have to take it out. So the appendix kind of exists here, and it can exist in lots of different positions, with retrocecal being the most common. So it usually hides behind the cecum. And this is a very important way and very basic way of identifying where the appendix is. And when someone has appendicitis, the pain is usually here. And it is known as McBurney's point. So it's where the one is here. And it is a third of the way between your ASIS, so your anterior superior iliac spine, the bony bit of your pelvis if you press on your hip, and your umbilicus. So it is a third of the way between here to there. And yeah, it is your classic first year medicine question. Where does it hurt when you have appendicitis, and is there at McBurney's point? We've talked a little bit about the appendix, so let's talk about the large bowel. So the large bowel is also a tube-like structure, but it is a little bit more complicated than the small bowel. It starts with the cecum, which is this section here, and everything comes in from the small bowel through the ileocecal valve here into the cecum. And this valve is there to make sure that nothing can go backwards. Then everything will go through the ascending colon and go, so we are, if we think about it, we are here in the right lower quadrant. And then all of the contents have to travel upwards towards the liver. So upwards this way to the right colic flexure, which is also sometimes known as the hepatic flexure, which is where your liver is. And then it will go through the transverse colon to the other side, to the left upper quadrant, where the left colic flexure is. This is sometimes known as the splenic flexure because the spleen is there. Then you get the descending colon, and then it will twist to the sigmoid colon and go to the rectum and the anus. So there are a couple of things that separate the large bowel from the small bowel in terms of anatomy, and what makes them look very different. The first one being the tinea coli. So you'll often see these strings almost on the large bowel, and these are called the tinea. They are longitudinal bands of muscle. They start at the base of the appendix here, and there's 3 of them with fancy Latin names: tinea libera here, which is in yellow, tinea ommentalis, and tinea mesocolica, which are both on the other side, but they wrap around here in the transverse, so they come forward a bit, and they end at the rectosigmoid junction. So the rectosigmoid junction is where the rectum here and the sigmoid colon meet, essentially, so around here. And they are useful because they are very strong bands of muscle. And essentially, the colon itself, the colon mucosa, is is longer than the longitudinal bands. So the bands are shorter than the colon itself. And because they're so tight, they bunch everything up together. They bunch the colonic mucosa together to form these outpouchings called the haustra. So this is why you often see the colon kind of looking like, and please forgive me, kind of looking like the Michelin Man, because of these haustras that are formed by the tinea contracting. And this is a very big difference between the large bowel and the small bowel. The small bowel is smooth. You wouldn't see anything like this on the outside. It also has these appendages, these fatty filled pouches that are called the epiploic appendages. And these are just another feature that differentiate the large bowel with the small bowel. And these are just fatty pouches that are attached to the outside of the colon. So yeah, you can see this. This is a nice diagram from Netters, I believe, and it is showing you all the different layers, and this bit is cut open. Yeah. Then we get to the rectum and the anal canal. And the rectum and the anal canal are very complicated structures that we still know very little about. But in very simple terms, the rectum is where all of the feces is contained before it is ready for evacuation, and it is evacuated from the body through the anal canal. This is the rectum up here, and it no longer has any of the tinea that the colon did. And then it will go down to the anal canal and become the anus at the level of the anorectal junction, which is around here. There's lots of weird and wonderful things. You get glands here in the column of Morgagni here, and some pits. Then you get to the anus essentially, which is a different material to the colon wall. So here you get the anoderm, which is more skin-like material, whereas the rectum itself is still mucosal, like you would feel inside your mouth essentially. And it's got a very similar structure to your mouth. So if you feel the inside of your mouth, it's that mucosa, but your lips are covered by skin essentially. And your anus, which is the other side of your GI system, has a very similar system going on. And yeah, the two main things to know about the anal canal is the two muscles in it. The big muscle is the external anal sphincter muscle here that you can see along the outside. This is under voluntary control, so most people can control their external anal sphincter. When the body is ready to evacuate the stool, they can relax that, and then you will manage to pass stool. Your internal anal sphincter is inside here, and that relaxes on its own, so it is not under voluntary control. When there is feces in the rectum, it will relax, and that sends a signal. That is a very complicated axis between the gut and the brain that controls that, but essentially that relaxes when feces comes into the rectum, and only when it is appropriate to do so will people relax their external anal sphincter to go to the toilet and evacuate. Okay. So after all of that, next question for you all. Which clinical landmark is commonly associated with tenderness in acute appendicitis? Is it Murphy's Point? Is it McBurney's Point or Lanz's Point? Or is it the Hasselbalch's Triangle?
Okay, so we've got some responses. Okay, so 12% have voted for Murphy's Point, 87% have voted for McBurney's point, and there are no votes for Lands or Hasselbach's triangle.
Perfect. So the correct answer is McBurney's point. And just to recap, McBurney's point is this bit here. So a third between your aces and your umbilicus. Your Murphy's point is the other big one that medical schools like to teach you about. But that is more a point for acute cholecystitis, so infection of the gallbladder. And it is somewhere around here, essentially. I have forgotten the specifics about it, but it is up here in the upper right quadrant instead of down here in the lower right quadrant where we want to be for appendicitis. Okay, very quickly, in terms of arterial supply to the lower GI tract, there are loads of blood vessels going in that region. So to break it down, just remember the abdominal aorta is what is going to be supplying all of the arterial supply. The celiac trunk, which is the first branch in the abdomen, will supply the upper GI tract. The stomach, the spleen, pancreas, gallbladder, esophagus, duodenum, up until the first third of the duodenum. That is what the celiac trunk does. Then the superior mesenteric artery, which is the second branch in the abdominal aorta, supplies the midgut structures. So the easiest way to remember this is actually to know a little bit about embryology. And although it is a little bit confusing, once you remember it, it makes it a lot easier to remember what arteries supply what. So the midgut in babies when they develop essentially becomes the distal duodenum, which is the last part of the duodenum essentially, and up until the first part, so the proximal part of the transverse colon. And so the first 2/3, let me show you on this. So it will go up to about here. And so that is the midgut, and that is what the superior mesenteric artery will supply. The inferior mesenteric artery, which is the third branch of the abdominal aorta, supplies everything after that. So from the distal 1/3 of the transverse colon down to the descending colon, sigmoid colon, and up until the upper anal canal. And then the rest of the anus is supplied by some of your more your arteries in the perineum. So this is just another depiction of that. The celiac trunk is a little bit more on top, whereas the SMA and the IMA is mainly what will supply your lower GI tract. This is the superior mesenteric artery. You can see here that it's got branches here all through the small bowel, and then it will also do your cecum, your descending colon, and 2/3, so up to here, if you guys can see that, of the transverse colon. And then your inferior mesenteric artery has its first branch up until here, the first third of the last third, of the transverse colon, and all the way down here towards the rectum. In terms of venous drainage, it essentially follows the arterial supply of the lower GI tract. So it's also got its inferior mesenteric vein, it's got a superior mesenteric vein. The important thing to know about the venous drainage of the lower GI tract is everything in the GI tract essentially drains into the hepatic portal vein. And that is a big chunky vein that passes through the liver. And then that makes sure that everything is filtered there before it goes back up towards the heart. And so the hepatic portal vein is made up of the splenic vein, the superior mesenteric vein, which is coming this way, and the inferior mesenteric vein. And that goes to the liver. Now, we're going to move on to our conditions very quickly towards the end. So an inguinal hernia so we covered the inguinal canal. An inguinal hernia is a protrusion of the abdominal contents through the inguinal canal. There's two different types. So an indirect hernia will go through the deep inguinal ring. I'm on obs and gynae at the moment, so that's all I'm thinking about. So it will go through the deep inguinal ring, and essentially your bowels will drop into your testes if you are a man. And then a direct hernia protrudes directly through the posterior wall of the inguinal canal, but not through it. So that is more on the side and does not go straight down like the indirect hernia does. There are quite key differences between the hernias. So the cause of an indirect versus a direct hernia is quite different. Indirect hernias, so the ones on this side, are usually caused by congenital failures of the processus vaginalis to close. And that means that is more common in young males and in infants. Whereas a direct hernia is usually acquired because of abdominal wall weakness, and this is why you see it more in older men. In terms of location, we've already described the differences between indirect and direct. And the same as pathway and scrotal involvement, which is quite important. So just remember, indirect involves the scrotum, direct does not. In terms of investigations and management, hernias are usually diagnosed clinically. You can elicit hernias by making the patient stand up, reduce the hernia, so push it back in, and then ask them to cough and see if you can actually feel the hernia popping out. You can use an ultrasound if it is uncertain, but you should be able to diagnose hernias clinically. For inguinal hernias, if patients are asymptomatic, so they're telling you they don't have any pain or anything like that, you can just wait and watch. And that is an option that a lot of people take because they don't want to have surgery. Your second line, so if patients do choose surgery, and this is if they are symptomatic, so is an open mesh repair, or you can do it laparoscopically as well. So you just put a mesh in there to close off the deep inguinal ring, or wherever the weakness is, and to make sure that the bowel does not protrude past that point. You have to do surgery if there are complications, a complication being obstruction, so when the bowel goes into the hernia and blocks it there, and strangulation. So when that obstruction becomes so tight that the blood supply is lost, then it becomes strangulated, and that is an emergency. And symptoms of those include pain, redness, nausea, and vomiting, because they are also having a small bowel obstruction since their bowels are blocked and don't have a blood supply, and they will be systematically unwell. So this is just a bit of a graphical representation of that. So obstruction just means that the bowel is stuck in there, but strangulation means when the blood supply is cut off from it and the bowel starts to die. So a question, a direct inguinal hernia typically occurs. Is it lateral to the inferior epigastric vessels, medial to the inferior epigastric vessels, within the deep inguinal ring, or is it through the femoral canal? Yeah, and I appreciate this is quite a mean question because I haven't said it directly, but just think about where you would see a lump in a direct inguinal hernia. Is it more lateral to the midline of your body, or is it more medial to the midline?
So we've got some responses coming in. We'll just wait a few more seconds.
Mm-hmm.
Okay, so 11% have voted lateral to the inferior epigastric vessels, 44% voted medial to the inferior epigastric vessels, 33% within the deep inguinal ring, and 11% through the femoral canal.
Perfect. So the correct answer is medial to the inferior epigastric vessels. And if we go back, essentially, your epigastric muscles will be running somewhere along here. And your direct hernias, if we go back to this one, will run medial to that. So closer to the midline of your body. If you imagine that your body, the midline of your body is around here, the way that I remember it is the direct one is the one that is closer to the middle, and so is medial to the vessels, which I think are being depicted here. This one here, and the indirect hernia is lateral, so further away from the vessel. And you can, yeah, that's right. So this is the vessel here. So the indirect one is lateral and the direct one is medial. And just remember this table if you want to compare the two. It's quite a good way of comparing them. Now, yeah, and it's not within the deep inguinal ring because the indirect hernia is what goes through the deep inguinal ring instead of the direct one, which is outside of that. Okay, femoral hernias, like the name suggests, femoral hernia is when a part of the intestine goes through the femoral ring. So we just talked about inguinal hernias that can go through the deep inguinal ring if it is indirect, but femoral hernias will go through the femoral ring. And it usually appears as a lump or bulge in the upper thigh area instead of in the lower abdomen or scrotum in men. So you also are diagnosed femoral hernias with a clinical examination, but differently to the inguinal hernias, you have to do surgical repair on them because there is a higher risk of complications in these ones, even if you're asymptomatic. Hiatus hernias are something to do with the stomach. Essentially, it is when the stomach pushes up into the thorax or the chest cavity through an opening in the diaphragm. There are two different versions. A sliding hiatus hernia is the most common, this one here, and the rolling hiatus hernia, which is more of an outpouching to the side of it instead of straight upwards, is less common, but yeah, you can see that here. Signs and symptoms wise, hiatus hernias are often asymptomatic. If you do have symptoms, they're very similar to GORD. So your gastrointestinal reflux. You get heartburn, reflux, chest discomfort, and you investigate it with an endoscopy, so sticking a tube down someone's throat, or you can make them have some barium, and then you make them swallow the barium, and then you take an x-ray whilst you're doing that. Not the nicest, either of them, actually. Yeah, and then once you've diagnosed it, if it is symptomatic, you can give them some lifestyle modifications. You can ask them to lose some weight, change their dietary habits, so less coffee or anything that induces their heartburn, for example, and also sleeping with elevating the head of the bed. So very similar to treating your acid reflux, essentially. And then as a second line, you can give them some medication, some proton pump inhibitors, or H2 receptor antagonists like ranitidine to suppress the acid in their stomach. And then third line, if none of that works, you can intervene surgically. So you can do a fundoplication for very severe cases. Yeah. And then just to go through them quickly as we are reaching time, gastroenteritis is just a general term that is describing inflammation of the GI tract. This can be the stomach, this can be the intestines, and it is usually due to a viral infection. The most common cause of gastroenteritis, especially in kids, is norovirus. And the other common virus is a rotavirus. And then sometimes bacteria can also cause it. So these are your common bacteria you find in food poisoning, essentially. Campylobacter, Salmonella, E. coli, and a rogue one that is parasite is Giardia. And yeah, they all cause gastroenteritis in a slightly different pattern. And once you get good at recognizing the pattern, you can understand which pathogen has caused it quite easily. In terms of medical school, I think in real life it's much more difficult, and you would do cultures and things like that. But essentially, this is just a table showing the differences. The viruses often have a very quick onset. So with like norovirus, you will get symptoms in about 12 hours or 24 hours. And you can get both vomiting and diarrhea. The vomit and diarrhea is usually very profuse, very watery, and of very high intensity. So you get quite projectile vomiting with norovirus. And these usually pass on their own. With bacterial gastroenteritis, with Campylobacter, for example, that is usually linked to undercooked chicken. So essentially food poisoning from undercooked chicken can cause nastier symptoms. You get some blood in the stool, and you don't vomit as much as you would with the viruses. Same with Salmonella. And also with E. coli. With the bacterial gastroenteritis, it's important to know which ones can cause bloody diarrhea, and that is your Campylobacter. Salmonella can be, and E. coli, specifically E. coli, the hemorrhagic E. coli, so O157, is what causes bloody diarrhea. And that is important to know, so you can counsel your patients that it's all right to have a little bit of blood in the stool if they are having a gastroenteritis-like picture, and not to be worried because it should pass on its own. And then finally, your Giardia is unique in the sense that its onset is always more than 7 days. So if you have someone who has eaten something dodgy or traveled somewhere dodgy more than a week ago, and they've come back and then started developing symptoms, maybe they will have a parasite. That is the way that it is usually written in your medical school stems. In real life, things are not as clear cut as this, but I still find it quite useful to have a guide like this. In terms of management for gastroenteritis, pretty straightforward. Encourage oral rehydration, so encourage them to take some fluids down as they can, especially for kids. You can put a little bit of apple juice or a little bit of Sprite. Just ask them to take a little sip every 10 minutes, whatever they can tolerate, to get something down. And just encourage them to still drink and still eat as much as possible. And then second line, if they cannot tolerate anything that they put down is coming straight back up, then you would consider admitting them to give them some intravenous fluids to prevent severe dehydration from happening, essentially. And third line is your use of antibiotics only if you think it's a bacterial cause. And most of the time for bacteria, we don't actually give antibiotics because our bodies are quite good at getting rid of the pathogen. So if you think about food poisoning, most people don't get antibiotics for food poisoning. You just rest at home for a couple of days and it's horrible, but your body does manage to get rid of it eventually. So yeah, I think that's it. Thank you very much. And I hope I haven't gone too far over time. If anyone has any questions, please ask, and I will try my best to answer them, although I am no expert. Thank you.
So thank you so much, Kiara. That was an amazing teaching session. Clearly, you know lower GI very, very well. So the feedback form is now available in the chat. Don't forget to fill this out to receive your certificates and discount codes for Teach Me Surgery and pass the MRCS. Also be sure to complete the Google form for a chance to win free access to the Geeky Medics surgical flashcards and their OSCE stations. And the link for that is also in the chat. Our next session will be on lower bowel and general surgery presentations, and that is tomorrow at 6:30 as well. So we'd love you to join us again. Make sure to follow us on our social media platforms. The links for this are available in the chat as well. You will also be able to receive updates on the upcoming sessions via these platforms. We'll also be posting SBAs on our socials for additional practice, so keep an eye out for those. Don't forget to visit our website where you'll find a resource bank with materials, not just for this session, but for all our other sessions in this teaching series. These resources include summaries and a question bank featuring extra questions that aren't available on our social media. To access them, simply create a free account on our learning portal. We hope you enjoyed today's teaching and found it enjoyable and engaging. Thank you once again for joining us, and we look forward to seeing you at our next session. Does anyone have any questions before we go? Okay. I think you must have explained everything really well, Kiara, because there aren't any questions.
Oh, good. Everyone should go enjoy their dinners, honestly.
Okay, well, if there aren't any questions, I think I'll end the session there. Thank you so much for teaching, Kiara. You've done a job.
It was a pleasure. Thank you so much for having me.
All right, everyone.